Hey,
Hey,
Thank, thanks for joining us today for part one in a series of webinars on medications for opioid use disorder. My name is Rachel Brandhorst, and I am the Department of Justice Grant Administrator for the Healthcare Authority. Through a Department of Justice Adult Drug Court grant, the Healthcare Authority has partnered with the Center for Justice Innovation to develop and implement a comprehensive initiative called the Washington State Treatment Court Opioid and Overdose Response Plan. And this plan focuses on providing Washington's treatment courts with training and resources needed to improve adherence to national best practices and address overdose risk among its target population. Before we begin today, we want to get a sense of who is in the room with us. So next, a survey question should appear. If you could please answer this question. And then I will hand it over to our first presenter, Tim.
great. And just take another few seconds to answer the poll, and then we'll share out the results in a minute.
It disappeared before I could vote. This is Judge Morgan.
one moment. Let me see if I can.
I relaunched it, so
Oh,
hopefully
great.
it's now.
Thanks, AJ.
Okay, hopefully you're seeing the results. Got a good mix of folks in the room, we've got court coordinators, case managers, some treatment providers, a judge, some probation officers. So thanks everyone for joining us.
Cool. So I will go ahead and kick it off. Good afternoon, everyone. My name is Tim Candela. I am the Drug User Health Harm Reduction Advisor here at the Washington State Department of Health. I'm housed within the Office of Infectious Disease. I've been working with DOH in this role and various other roles in our office on and off for the past 10 years, specific to harm reduction. Our office supports syringe service programs. We fund them throughout the state, whether that's with direct funds and or through in-kind support with harm reduction, risk reduction equipment. In addition, our office has a overdose education and naloxone distribution program. Previously, my life at DOH, I did a lot of direct service outreach, serving people impacted by incarceration, individuals who use drugs, homelessness, etc. So very grateful to be able to present with you all today. Today, I will be giving a very, very, very high level overview of harm reduction within Washington State. So we'll be looking at some of the data within Washington State. We're going to go over some of the practice and what that looks like in application, and also where we are at and why we got here. So just really quickly, can folks see my screen? Just by a raise of hands. Okay, cool. And then let me see if my poll buttons work before I move along. Bear with me. Okay, cool. So I did my intro. Here's a grainy photo of Mount Rainier. It's one of my favorite places to hike around. But today we're going to talk about harm reduction. So at its core, harm reduction is a very, very practical set of strategies aimed at reducing negative consequences. So I know when we think of harm reduction, it's most generally applied to drug use. What I will say is that you can apply harm reduction to many, many other ways that we live within our lives. I know one of the things that people like to commonly bring up, and I know some folks have mixed feelings about this as an analogy, but driving a vehicle is inherently dangerous. Up until 2015, it was the number one cause of accidental death, which was surpassed by overdose. But what do? We put things in place to make driving more safe. So that's regulation, that's putting airbags and seatbelts, etc. So just really, really practical approaches at addressing negative consequences. Also, importantly, is that harm reduction just isn't about serving individuals who are actively using drugs. Harm reduction, the principle and ideology and framework can be applied whether you're engaging with somebody who wants to focus on abstinence, whether that's an individual who wants to continue to use drugs, or somebody who wants to lessen their drug use. And from surveys of needle exchange participants, there are folks across that continuum where folks do want treatment, or folks just want to use less, or folks don't want to quit using for a whole host of reasons. And harm reduction meets folks where they're at as it regards their drug use. Then we have capital HR harm reduction, which is more related to the movement of social justice and addressing the rights of people who use drugs. And so I know the audience today is therapeutic courts, and many people argue that drug use should not be criminalized, and that it should not be handled within the courts, because it is not a criminal activity nor a moral failure on that individual. And we'll talk briefly about that as well. So I like this little infographic. It helps break down the big HR, and that is the political movement that is ending the structural violence that occurs to people. Then we have little HR, and little HR is the approach. That is the non-judgmental, non-coercive, meeting people where they're at approach. It's making things low barrier and accessible. So some of the programs that we operate, people can come in and receive services the same day, whether that's testing for infectious disease, whether that's receiving naloxone, or whether receiving holistic health care. It's giving folks and meeting their needs. And then we have risk reduction. And I think this is important. A lot of folks are like, oh, we do harm reduction because we give out naloxone. And I commend that. That's really, really exciting. And we should be giving out naloxone. But giving out naloxone is the proper medication for opioid overdose. And so, you're giving out risk reduction supplies. Even if you're giving out syringes or sharps containers, you're giving out risk reduction supplies. How you distribute those supplies will determine if you're practicing harm reduction. Is it low barrier? Is it non-coercive? Is it non-judgmental? Are you supporting people with where they are at? So just really wanted to highlight that briefly. So here's a picture of one of the pioneers of harm reduction within the United States. This is Dave Purchase, who propped up a card table in Hilltop, Tacoma, not too far from where I'm sitting right now, because he was tired of watching his friends die from HIV and AIDS. This was at the height of the HIV AIDS crisis, and a lot of harm reduction interventions internationally really, really started to creep up at the height of the HIV AIDS epidemic. Because gay and bisexual men and people who injected drugs were disproportionately impacted. And it was a practical strategy. He said, hey, you come give me a used syringe and I will give you a sterile syringe. And what we saw is that one practical strategy had dramatic impacts on HIV and public health, not just within Washington state, but throughout the country and throughout the world. So what we know today, and this has been borne out in literature throughout the world, is that syringe service programs and a harm reduction approach is bar none the most effective HIV prevention strategy amongst people who use drugs. What I will state, in 1992, needle exchange became legal in Spokane in Washington state. And you can see this graph. These are HIV case counts. And you see HIV start to drop down precipitously. We also made great advances in medications for individuals living with HIV around 92, 93. But another good example is more recently, Scott County, Indiana, about 10 years ago, had one of the more recent, largest HIV outbreaks recorded in US history that was all related to injection drug use. Indiana state government at the time did not allow needle exchange programs. Mike Pence at the time as the governor gave special authorization to implement harm reduction needle exchange programs within Scott County. And what they saw immediately was HIV cases plummeted and then ceased to exist. So we know these strategies work, and that they also address many other things, these harms that we talk about, such as overdose, soft tissue infections, and hepatitis C. We're also dealing with an unprecedented overdose crisis. I don't need to spend a whole slide on this. We've all been living in this. We've lost friends, family, colleagues, and harm reduction is really at the forefront of addressing this. So when we're talking about the overdose crisis, we're not just talking about one drug, we're talking about multiple drugs. I don't want to spend too much time. We will send these slides out, but what this slide really shows is that when folks do die of overdose, they typically aren't dying from one drug alone. We're talking about poly drug use, and we're primarily talking about synthetic opioids, fentanyl, and methamphetamines or other stimulants. And as you can see, out of all the drugs listed on this list, heroin overdoses are lower than anything else. We really don't see heroin in the drug supply anymore. It has been almost fully replaced by fentanyl. And we also have, I think it's very important, especially in the context of practicing harm reduction, to keep our eyes on racial disparities, which we know our American Indian, Alaska Native community members are disproportionately and always have been disproportionately impacted by overdose. And I know a lot of people think of overdose as this white issue. And yes, while the white people have the highest incidence of overdose, when we look at rates, it also shows another story. And so both stories can be true, and we need to acknowledge that and figure out ways to address that that are culturally advantageous for those communities. Really quickly, there's a lot of slides on this. My supervisor does a whole history of drug policy, but I share this slide as a paradigm shift, as I mentioned before. A lot of us in harm reduction believe that drug use isn't a moral failure, that it isn't a criminal behavior. And a lot of what our narcotic laws are based around are to marginalize a community. And our first anti-narcotic laws in the United States were in San Francisco, and it was specific to banning opium, didn't mention other forms of opium, and it specifically targeted Chinese communities. We saw the same thing with enhanced sentencing for possession of crack, even though it was exactly the same as cocaine. And so we see these things throughout history around, we base criminality of drug use more related around communities and not necessarily the drug use. And if we actually looked at some of the science, we might have a different paradigm shift around the impacts of drugs. And that's not to say they don't have negative consequences. During Prohibition, alcohol became illegal and it became exponentially more dangerous because it was unregulated. And people were becoming blind because of that. So I know this is going to be talked about more in depth by another amazing person. So I just want to say harm reduction can be practiced within therapeutic courts. I think one of the big things is clinical decisions should be made by licensed clinicians in consult with the judges, that this is that partnership. Participant-led goal planning, really self-determination is the key part of that. And then knowledge base of all your community resources and comfortability of referring folks there with the knowledge that while they may be required not to use drugs, the reality is that people might return to use, even if that goes against their court sanctions. And how can we keep people safe so we can keep them in the game? And then again, celebrating any positive change. Substance use disorder is a chronic condition, and return to use is the norm, like we just kind of briefly talked about. Leveraging resources that are available within therapeutic courts. I know some have housing resources, which housing is healthcare, and I've seen firsthand, anecdotally, personally, and professionally, how housing really, really can be a game changer when it comes to people's drug use. And then one thing that I often say is that when it comes to this work, and I saw it when I was doing direct service, is that the relationship is the intervention. We are complex social animals. We have complex needs. And oftentimes I would get folks into housing, I would get them into treatment, but the thing that they kept falling back to is I don't have a network. So really giving people that community network is super, super important. Again, being aware of your own biases, rolling with the resistance, motivational interviewing, all those good things, care navigation. Next slide, I'm just going to go in. That awareness and practice for harm reduction is that markers of success should be rooted beyond abstinence. We need to address the social determinants of health for individuals. And again, emphasize the success beyond abstinence, little wins, big wins, such as making an appointment on time. And that's it. I want to leave more time for my colleague, Sean, who's going to go into more specificity around overdose. And then hopefully we'll have some time to answer any questions. So with that, I will go ahead and kick it to my amazing colleague, Sean Hemmerly.
Hey, thanks, Tim. Give me 1 second, folks, and pull the slides up here. All right, so just to confirm, on your screen, you should have a full screen slide, fire by the beach side. Can I get a yes from someone?
Yep.
Great, thank you. I lost my thumbnail. No, proverbial thumbnail. No. So gotta reboot this. Just folks, bear with me. I'm usually Teams, not on Zoom, so. Please put up that. All right, so let's try this again. On your screen, you should have a full screen slide of the Fire by the Beach slide, correct?
No.
No. Okay. This is what happens. One last time for the kids. How about now?
Yes.
Awesome sauce. All right. Good afternoon, and thank you all for being here, taking time out of your day to learn about some of these topics. And thanks again to Tim for kicking us off here. My name is Sean Hemmerly. You see him pronouns. Work here at the Washington State Department of Health. My title here at DOH is Overdose Education and Naloxone Distribution Consultant. I work on what's called our Overdose Education and Naloxone Distribution Program. A couple things before we get going. The slide deck and Tim, have been shared with AJ, so she'll work on getting those out to you if you're interested later on. For those of you who are familiar with this topic, opioid overdose, I hope you learned something new. Some of the steps are kind of set in concrete. Some things sort of evolve. So what we go over here today might be new for you. If it is, please understand I encourage questions. Okay, so I've got the chat window open. Feel free to throw questions in chat as I go along. And I believe we'll have time here at the end as well to do a little Q&A. Contact information here in case anyone would like to reach out to me somewhere down the line. You'll also find some links here regarding our program and some services that we offer. This link right here for our Drug Users Health webpage. You'll find some additional training materials, including a one-pager front and back. We have it in 6 different languages that covers opioid overdose response and the administration of both nasal and injectable naloxone. If you are interested in scheduling a training for the agency or organization that you work for, you can fill out this form right here, and we will follow up. We offer trainings on all sorts of topics related to drug user health, including overdose response, harm reduction, backgrounds on opioids and stimulants, Basically anything that involves the health of people who use drugs. We're happy to speak with you about that. And lastly, if you know of an organization that is interested in distributing naloxone to their clients, participants, patients, they can either apply to our program using this link at the bottom, or if you are affiliated with a tribe, a tribal health organization, or an urban Indian health organization, and you need naloxone, you can fill out this registration form right here. And again, if you have any questions down the line about which form is best for you all to use, please feel free to reach out to me. And yes, Tanya, we'll make the slides available. Absolutely. So my goals for today, we're going to get right into it. We're going to take a look at the steps to take to recognize and respond to an opioid-related overdose. And that's also going to include post-overdose care, which is a really important component about this. And then we'll wrap up with some risk reduction strategies that you might want to consider when talking about opioid overdose. And before I get going any farther, just so that we're on the same page, you're going to hear me say the word naloxone a lot over the next 20-ish minutes or so. When I say naloxone, I'm talking about the medication. It's either injectable or intranasal that you can administer to someone they're experiencing an opioid-related overdose. By opioids, I'm talking about drugs and medications like fentanyl, heroin, methadone, oxycodone, Oxycontin, Percocet, things like that. Okay, naloxone doesn't work on any other drug overdose, only opioids. Okay. So an overdose simply occurs when your body gets overwhelmed by a substance. Overdoses can be fatal or non-fatal, meaning the person dies or lives. Overdoses can happen from legal substances like alcohol or certain prescription medications or even over-the-counter medications. Or they can happen from use of an illicit substance, an illegal substance, something like crystal methamphetamine or maybe illicitly manufactured fentanyl. Opioid overdose is all about the person's breathing. Okay. The breathing becomes suppressed. You see, in our brain, we have what are called mu opioid receptors. That's MU, not like a cow mu, MU. Okay? For our purposes here, the mu receptor is this little Y-shaped bluish purple symbol. All of us have these in our brains. When we take opioids, or when we're given them, opioids bind to those mu receptors and trigger the effects. Well, those mu receptors are also involved in regulating our breathing. So if we take too much of an opioid at once, or if we're given too much at once, those receptors become overwhelmed and our breathing becomes suppressed, slows down, or it might shut down entirely. And if we don't breathe, bad things happen, right? So the goal during an opioid overdose is to get the person breathing again as quickly as possible. We don't need to get the person awake and moving around. They don't need to be standing. They don't need to be talking to us. We simply want to get them breathing again, right? So keep that in mind. It's really important. We do this by giving the person naloxone. So for our purposes here, the naloxone would be this little ball with a bunch of little balls inside of it. Naloxone binds to the mu receptor, kicks the opioids off. The opioid in this case would be this purple ball, kicks the opioid off, and blocks other opioids from being able to attach, being able to bind, thereby allowing you to start breathing. Okay? That's it. All naloxone does. If I can impart one thing to you all here today, outside of the steps to take to respond to an opioid overdose, it's going to be this. Regardless of the drug you think that person took to cause the overdose, if they are showing you the signs and symptoms of an opioid overdose, which we'll go over here in just a second, you give that person naloxone without hesitation. I know a lot of the word on the street, popular wisdom, that's the right term. A lot of messaging out there is that fentanyl is in all the drugs, even things it's not necessarily supposed to be in. People sometimes think, yeah, it's enough fentanyl is in all the cocaine or in all the meth. Listen, It's not necessarily the case based on the data we have. There's certain places across the state that offer drug checking services, meaning if I just purchased a drug on the street or on someplace like Snapchat or the dark web, and I'm curious about what might be in it, I can take it to one of these places and they'll check it for me. They do what's called mapping, and they'll show me exactly what's in the drug. Based on the data that we see from those drug checking places, we're not finding fentanyl in drugs that it's not supposed to be in, meaning we're not finding fentanyl in drugs that are being sold as something other than an opioid. Okay. Does it happen from time to time? Yes. Okay. Nothing's ever 100% across the board. But it's not at any sort of alarming level, sort of alarming rate, as it might be in other places in the country or across the globe. Places maybe up in like Vancouver, BC, or back east in like Philadelphia or New York City. Okay. It does happen, yes, from time to time, but strictly speaking, not on any grand scale. But there's always that possibility. So all you think that person took was maybe some ecstasy or some meth or some Valium, all three of which are not opioids, but they show you the signs and symptoms of an opioid overdose, give them naloxone. Here's the thing. If they don't have opioids in their system, nothing's going to happen. You're not going to hurt them. Because again, the only thing naloxone does is kick opioids off those brain receptors and block others from being able to attach. You will not hurt the person. If this is brand new for you, this right here is what you want to remember. All right, these are the signs and symptoms. The ironic part about this whole thing is that the actual administration of naloxone is pretty cut and dry. It's pretty simple. There's an extra step involved with the injectable version, with having to draw it up out of the syringe. We'll go over here in just a second. But the administration of the drug is the easy part. The tricky part, the nuance, happens in like the before and after, like recognizing when someone needs help, steps to take to, in between giving doses and post-overdose care, which isn't necessarily something that the manufacturers can get into great detail on the small sort of packaging, which is why trainings like this are beneficial, because we can sort of think through these steps and what might occur. But signs and symptoms. Remember, it's the breathing. So struggling breathing or lack of breathing is usually going to be the most standout apparent sign. Because remember, again, it's a respiratory emergency. However, this person might also be showing you that they have blue skin, blue fingernails, blue lips. If they're a person of color, darker complexion, their lips or skin might be kind of white, right? They might also be unresponsive to stimuli, shaking their shoulder, shouting their name if you happen to know it. It does not have to be all three of these signs and symptoms at once, right? One or any combination of these, something is happening and you have to act. Erica, great question. Erica asked in the chat, is mouth-to-mouth, i.e. rescue breathing, needed after administering naloxone? Yes, we're going to get into that, Erica, in just a second. So let's pretend, and I realize we're coming from all across the state, usually during these trainings, or if I'm doing one in person, I'll pick a local landmark and pretend someone's overdosing there. But since we're statewide here, I'm going to throw a dart and pretend that we are in, let's say, downtown Mount Vernon. Okay, Skagit County represent. There's any Skagit County folks on the call. We're over there by those train tracks, and we see someone sitting curbside. We think they might be in trouble, right? So we approach them. We look for the visual signs. We just went over them on the previous slide. So you should hopefully be saying to yourself in your head, hey, I'm looking for blue lips. I'm looking for struggling breathing. I'm looking for white skin. I'm checking their responsiveness. Let's pretend they aren't breathing. So we're going to assume an opioid overdose. Before we do anything else, we're going to check for a response on this person. And I'm going to exit out this. Now, usually I run the risk of exiting out the slides to go full screen here so you can see me a little better, but I'm going to trust that you can all see me on the phone. Check for a response. We're going to do a sternum rub, also known as a sternum tap on this person. We're going to take two knuckles, our pointer and our middle knuckle. We're going to rub and tap on that person's sternum, on their breastbone, for about 10 seconds, as hard as we can. Okay? If you do this hard enough and they're not overdosing, they will get up and say stop. Okay, that hurts because it really does. Try it out on yourself for a second or two and see what happens. Okay. 10 seconds of the sternum rub. You don't take it to an ice bath. You don't put it in the shower. Nothing like that, right? If you happen to know their name, you can also shout their name, shout, hey, buddy, hey, are you okay? Stuff like that. You can also shake their shoulder if you like. But usually 10 seconds or so of the sternum rub is going to let you know where the person's at and if they need additional help. If they respond to the sternum rub, hey, you can just stop and just make sure they're okay. If they don't respond to the sternum rub, the next step is that we would encourage you to administer the first dose of naloxone, assuming that you're by yourself. Administer the first dose of naloxone, and then call 911. If you're able to have 911 on speaker while you administer the first dose, great. But otherwise, don't let anything get in the way of you administering that first dose as quickly as possible. Okay? I can't stress this enough. It is incredibly important to get that first dose in that person's system and working ASAP. It can take upwards of 10 minutes for that first dose to fully make its way to the brain and saturate receptors. It might take effect sooner than that, but for it to make its way fully through the system into the brain, usually around 8 to 10 minutes. So no hesitation, get that first dose in the person's system working. However, don't forget to call 911 because what the person's overdosing on might not be an opioid. And if that's the case, all of them naloxone. So we definitely want to get EMS on the way, especially for those of you folks calling from more rural parts of the state, where it could take upwards of 10, 20, maybe 30 minutes or longer for EMS to arrive. Washington State gets rural very quickly. I'll start off with a demonstration of injectable naloxone. Injectable naloxone kits come in all shapes and sizes. Our program hands out supplies that have these sleeves. They have instructions printed on the outside, but some places hand out kits that look like this. This one came from our buddies over at the Tacoma Needle Exchange here in Pierce County. This one came many years ago, folks down in Olympia, Thurston County. It could be in different packaging entirely. If it's a brand new kit, there will be 2 doses inside, and there will at least 2 doses. Sometimes we'll build kits with 3 or 4 doses, but injectable naloxone kits will have at least 2 doses inside. They're brand new. And they'll be in little single dose vials, like on the screen, what I have in my hand. There'll be a little plastic cap that you'll pop off, like that orange cap here on the slide, and you'll notice a little opening on the top of the cap. That's what you're going to insert the needle through. Inside the kit, there'll be an equal number of needles and syringes to vials. You take out a needle and syringe, remove it from the packaging. I'm going to leave it on, but you're going to want to remove this plastic cap from the needle and then draw a little bit of air into the syringe by pulling back on the plunger. Just do about halfway or so. Once we've done that, we're going to insert the needle down through that opening in the cap, and we're going to puff the air into the vial by pushing down on the plunger. This will help fill the vial up and help us draw the liquid up. While leaving the needle in the vial, invert it, turn it upside down, and then one smooth, slow motion here. We're going to start pulling back on the plunger while also removing the needle from the vial. We want to keep the tip of the needle in the liquid. Okay, be sure to do that. And one smooth, slow motion here, just pulling back on the plunger and removing the needle. Once we draw the liquid up, there will still likely be some air in the syringe. We want to get rid of that. So to do so, we give the syringe a couple little flicks and push slowly up on the plunger, maybe another flick or 2, slowly up until we have all naloxone. Now, this is a muscle injection, not an intravenous injection. So we're not as concerned about a tiny bit of air being in here as we would be if this were an IV injection. So if you still see a cc, a line, and cubic centimeter or 2 of air in here, it's okay. Don't spend a whole lot of time on that. Next, you can inject this into any muscle. Thanks. Inject this into any muscle. Upper outer shoulder, upper outer buttock, upper outer thigh. We would recommend the thigh. Most folks, regardless of how they've been living their lives, are usually going to have a fair amount of muscle on their thigh. Upper outer shoulder, upper outer buttock, bicep, maybe not so much. This needle is really long and it's really thick. we don't want to hit the wrong spot, which we can kind of easily do, especially with the shoulder. You might hit the shoulder blade. So upper outer thigh, usually going to be the safest spot. A little difficult to portray here on camera. So we're going to pretend inside of my palm is the person's upper outer thigh. We're going to hold the needle and syringe firmly, their thumb on the plunger, hand wrapped around, about an inch or two away at a right angle from the thigh. This needle will go through all sorts of clothing, jeans, sweatpants, shorts, tights, leggings, all that. This needle will go right through. If it's wintertime, cold weather, if someone's really bundled up, lots of thick rain gear, maybe like Carhartt kind of gear that's kind of thick, you might want to remove a layer, but don't spend a whole lot of time. Okay, this needle will go through a lot of different types of clothing. Again, holding it firmly, right angle, about an inch or two away. One short, firm motion, inject it into the thigh. Get that needle down into the muscle. All right, don't just leave it dangling out there on the edge. Get it down into the muscle. Once you've done that, simply push on the plunger, inject the liquid. That's it. If you happen to have a nasal naloxone kit, it's a brand new kit. Inside the box, there'll be 2 doses. Right? Your kit may say Narcan on it. It might not, and that's fine. Narcan is simply a brand name product. At this point in the game, there's 5 or 6 or so different nasal naloxone products in the market now. So as long as it says naloxone, got what you need. Inside the box, again, 2 doses. They'll be in little blister packs like this. Simply take out one of the blister packs, peel off the back, remove the device from the packaging, and it's ready to go. You don't need to do anything else to it. Simply got to hold it like this, thumb on that plunger part, fingers on the outside. As long as you can reach the person's nostril, either nostril will work, you can administer this. Simply insert it up the person's nostril as far as your knuckles will allow. Push all the way on the plunger. Remember, this is a single dose. We give a full dose each time. So push all the way on the plunger. I suggest leaving this in their nostril for about 2 to 3 seconds after you've administered it. We want to make sure they get all the spray. There's not a whole lot in here. So don't do it in like one really super fast sweeping motion. All right, just leave it in their nose for a couple seconds after you've administered it. Take it out and you're done. That's it. I'll talk about what to do. I'll address Erica's question about rescue breathing and what to do in between giving doses and afterwards in a second. Any questions, though, about the administration of the drug? And again, you can throw those in chat. Feel free to shout them. Okay, so next step, begin rescue breathing. And AJ, just check in. Are my slides still on the screen, or have I gone?
Yep.
Okay, great. Thank you. Well, I'm going back there. Our computer's got a mind of its own today. Begin rescue breathing. You want to wait 3 minutes in between administering doses of naloxone. I realize on different packaging, different training materials, there's mixed messaging. Some packaging might say wait 2 to 3 minutes. Some packaging might say wait 3 to 5, 3 to 4. We stick with 3 minutes. It's a solid number, no wiggle room, no ambiguity. Wait 3 minutes. Give the naloxone time to work. So if you don't have a timer, count to 180, whatever you gotta do. But wait a full 3 minutes. Begin rescue breathing. Remember, this is a respiratory emergency. At the end of the day, oxygen is the antidote. And if you provide rescue breathing correctly, you're going to help expand and contract the lungs and get oxygen to the brain. Now, I realize not everyone has gone through training in CPR or rescue breathing, and it's going to feel like forever. Yeah, exactly, Sarah. Yeah, it can feel really fast or really long, depending on your state of mind. But really important to wait full 3 minutes there. I'll go through a quick rundown of rescue breathing. I'd encourage you, if you want to learn more about this, there's many different ways to get trained from CPR, Red Cross, places like that. I can't emphasize the importance enough of rescue breathing. All right. There's places some of you might have heard about, not here in the States necessarily, but in other countries. They're called safe consumption sites, safe injection facilities, places where people can come and use their drugs that they purchased on site. And if an emergency happens, there's medical staff available to help them. What's funny is, I mean, not funny necessarily, haha, but more ironic, is that overdoses happen in those sites all the time. There's never been a fatal one, but overdoses happen all the time. Thing is, medical staff in those places, their first course of action is to administer oxygen before they give any naloxone. Right? They'll give oxygen for like a minute or so and just see what happens. And the majority of the time, that works. The person doesn't even need naloxone. So I can't emphasize rescue the importance of it enough. Right? If you're going to do this, get the person flat on their back on a hard surface, kneel down next to them, visually inspect their airway first. So look inside their mouth. We want to make sure they have a clear airway, main airway in this case. If you see an obstruction, try to remove it somehow. So if it's not solid, you can try to roll them on their side away from you, firmly tap the back of their head, back of their neck to try to help dislodge it. Some people would suggest never putting your fingers into someone's mouth if they're not breathing. It's up to you what you feel good about doing. So if you see an obstruction that you feel like you can remove, your call. Once you visually have a clear airway, you give the person 2 short mouth-to-mouth breaths. You do so by pinching their nostrils, put your mouth on theirs, and 2 short mouth-to-mouth breaths. We want to see their chest rise. If their stomach rises, or if nothing rises at all, there's still a blockage, there's still something going on. So we basically just have to start over. But once we see their chest rise from those 2 short breaths, we continue giving them 1 full breath every 5 seconds. Again, 1 full breath every 5 seconds. Continue this process for 3 minutes. How many of you, and you can respond either in chat or by the reaction button, shouting it out, how many of you all have heard stories about people sometimes needing 3 or 4 or 5 or more doses of naloxone to help them out? Yes. I hear stories like this all the time. Okay. And someone will come up to me and say, hey, yeah, we had to give Bob 8 doses last night. My immediate reaction is, I hope Bob lived. Usually Bob did. And then I ask, how long did you wait in between doses? And what was your intention? Usually when it comes to the question about how long they waited, they'll say, well, we can't remember. Or, well, we just gave a couple back to back really quickly because we thought that would work better. Folks, remember those mu receptors I talked about a few slides ago? We don't have an infinite number of those in our brain. Okay. For most full-grown adults, 2 doses of this type of naloxone will be sufficient to saturate every single mu receptor in our brain. And giving someone more than that in like a 30-ish, 40-ish minute time span is redundant. It's sort of akin to me. Let's pretend this cup here can hold 30 ounces of liquid. It would be like me pouring 60 ounces of liquid into it, not drinking anything as I go along, right? The additional oxygen just won't have anything because the mu receptors will already be saturated. And this can also, by giving someone more naloxone than what's needed, for folks who take opioids on a regular basis, can impact or increase the chance that they're going to experience withdrawal symptoms once they're finally awake. And we want to avoid that whenever possible. So remember, wait 3 minutes. And then also remember what the intention is. We just want to get them breathing again. We want them breathing on their own, 1 full breath every 5 seconds. Same exact way that we provide rescue breathing, that's what we want to see from them. So when it comes to the second question, what was your intent? Folks will sometimes say, well, we didn't think they were safe until they were talking or until they were moving around, things like that. We just want to get them breathing. So begin rescue breathing, do what you're trained. If you're trained in CPR and are able to do chest compressions and rescue breaths, great. Do what you're trained in, do what you're comfortable with. At the end of the first 3 minutes, reassess the person's breathing. Again, we want to see them breathing on their own, 1 full breath every 5 seconds. If you see that, great. You can just stop and monitor their breathing. If you know for sure they aren't breathing yet, or if you still feel like they're on the cusp, go ahead, administer another dose of naloxone, exact same way, and just continue that process until EMS arrives, or until the person starts breathing and wakes up. If you need to leave the person, got it, AJ, thanks. If you need to leave the person for whatever reason, or if you're not going to perform rescue breathing or chest compressions in between, we would encourage you to roll the person into the recovery position. The idea behind this is that if they happen to vomit, it will hopefully roll up the side of their mouth and choke on. Just be sure that if you do this, make sure you're resting the person's head on top of their hand. You want to make sure they have a clear airway in this case. Once the person wakes up, starts breathing on their own, stay with them whenever possible. Right? Remember, naloxone doesn't kick the drug they took out of their system, just blocks it from getting to the brain. And once naloxone wears off, which can be anywhere from 30-ish to 90-ish minutes, there's always a possibility the person might slip back into an overdose. So stick around, keep an eye on them when you can. This middle bullet here, depending on what your feelings, thoughts are about substance use, or depending on where the overdose occurred, you may not be able to do it, may not want to do it, but I can't emphasize enough the importance of it. For people who take opioids on a regular basis, if they're given naloxone, they're most likely going to wake up in some form of opioid withdrawal. And opioid withdrawal is really unpleasant. And the most logical response is the person's going to want to take more opioids as quickly as possible. Makes total sense. However, they're in a really vulnerable spot right now. So if they take opioids right away, well, they likely still have naloxone in their system. So it's going to block the effects and will actually wind up making the person feel worse than they already do. If you know for a fact their plan is to use opioids again as quickly as possible, or if you suspect that, if you are able to talk with this person and help them formulate a plan for their next use, this can go a long way towards preventing another overdose from occurring. Meaning, can they wait as long as possible, ideally a couple of hours? Can they make sure someone's with them the next time they use? Very important. If they can't, can they call, and we'll talk about this here in a second, never use alone hotline. Can they make sure they have more naloxone available? Very important. Can they start with a small amount? Go low and slow. They can always use more if they want to. Start with a small amount. Lastly, if you're unsure about the condition, get them to the hospital, get them to the ED. So they might have something going on internally that you don't know about or you need. When we talk about risk factors that are associated with overdose, with opioid overdose, this here is a list. It's not in any order of importance. It's not comprehensive. I'm sure there's other risk factors out there. Two that I would emphasize if I was talking to someone about this, because these seem to be the two that are most prevalent in the overdoses that I read about and hear about. Number one, polysubstance use. Number two, using alone, using drugs by yourself. Poly just means one. Person took more than one drug. Okay. People like to feel different ways. They like to experience different highs. They like to combine drugs, mix drugs. For those of you who might have worked in the substance use treatment field for a while, or maybe you have lived or living experience with substance use, you might be familiar with this term drug of choice, the idea that someone has a singular drug of choice. We've kind of moved away from it over the past couple of years. Not for everybody, but a lot of folks nowadays use what's accessible, use what's in front of them for a variety of reasons. Again, thinking as harm reduction, it's not about the why, we're thinking about what can happen. It is risky when you combine different drugs, especially drugs that you buy on the street because you don't know what's in them a lot of times. And also, especially if you mix opioids with other drugs that suppress your breathing, like alcohol or something like a benzodiazepine, Xanax or Valium. And then using alone. I can't tell you the number of overdose reports and anecdotes and stories I hear about and read about. Start off, person was found alone in bedroom, person was found alone in motel room, person was found alone in SRO. We get it. People prefer sometimes to use alone. Sometimes they might have to use alone. They have to hide their use from their friends, their family, their case managers, whomever. Drugs are expensive. You might not want to share. I get that too. When we talk about using opioids purchased on the street, not from a pharmacy, it's incredibly risky right now because they're most likely illicit fentanyl, and illicit fentanyl is a very, very potent opioid. And even for folks who have a very strong tolerance, they're putting themselves at risk when they use by themselves. This here is for an organization called Never Use Alone. Some of y'all might have heard about these folks. The link right here is for an NPR story. NPR, This American Life, did on them a few months back. It's really interesting. I encourage you to check it out if you're interested. And I would also encourage you to share this phone number with folks. We're not affiliated with them. They're not affiliated with us. The idea is that if you're about to use a drug, any drug, this is not limited to opioid use, but any drug where you're concerned about an overdose occurring, call this number. And this is all volunteer run. The volunteer will stay on the phone with you while you use, or they'll call you back after a few minutes and check in. And if you don't respond, they'll call paramedics and have EMS sent out to where you're at. It's not a perfect fix. Thanks, AJ. It's not a perfect fix by any stretch, but it is a resource that you can share, and it does work. Strongly encourage you to share it with people. They do have an 800 number as well. This 877 number, though, does work nationwide. I'd encourage you to, if you're going to share this, just check in from time to time on their website. Make sure you have their most up-to-date. They have changed their number at least once since they've been up and running. When it comes to risks with opioid use and overdose, again, the two that I'm emphasizing, polysubstance use and using by yourselves. So knowing what's in your drug, know what you're about to use. The overdose spike that we've seen over the past 6-ish years, 6, 7 years, is because of the shift in the drug supply, plain and simple. Okay, it's not because more people are using drugs. It is because the drug supply has gotten very volatile for a number of reasons that we don't have time to get into. Even people who have a very strong tolerance for opioids can sometimes have difficulty handling what's being sold out there. So folks can utilize drug shipping services. If they can find a reputable supplier and stick with them if possible, they can, anything they can do. At this point in the game, there really is no wrong approach to knowing what's in your drug if it's giving you factual information. Using with someone nearby, use with a friend, have some sort of accountability system. All right. Because overdoses happen and they happen fast. Or fentanyl related overdoses, the onset of the symptoms happen much faster than overdoses related to other drugs like heroin or other prescription opioids. Know about your tolerance. Unfortunately, again, because of the purity and potency of illicit fentanyl, sometimes tolerance doesn't matter because we're talking about a drug that's measured in micrograms, a millionth of a gram. So you could have a very strong tolerance, but you still might not be able to process what you're taking. Lastly, understand the impact of your route of administration. Pre-illicit fentanyl, we could advocate in good faith that using different routes of administration, different ways of taking your drugs, smoking, snorting, injecting, might impact the risk or the chance of an overdose occurring. Ordinarily, intravenous injection, IV injection, is going to have the highest bioavailability. You're going to get the most of the drug fastest way possible. Smoking something a little bit lower, snorting something a little bit lower. Don't let folks tell you that, hey, I'm just smoking this drug, or I'm just snorting, I'm just eating it. I'm okay. I'm not injecting. I'm going to be fine. Because of the volatility in drug supply, that way of thinking isn't necessarily as valid as it used to be. Yes, it still does impact things, but it's not quite the game changer that it used to be. Lastly, our Drug Users Health webpage, you can find more resources on here, training videos, copies of the standing order, handouts, links for our program, and thanks.
Great, thanks so much, Sean. If anyone has questions, please feel free to drop them in the chat for either Tim or Sean. We can stay on a couple minutes. And with the couple minutes we have left, Spencer's going to drop into the chat our feedback survey. If you could take a couple minutes to fill that out, that would be super helpful. And a week from today, we'll have another session at the same time, just going a little bit more in depth into therapeutic court practices, some of the topics that Tim had touched on. So we hope to see you next week at the same time. And here's a registration link for that meeting. And thanks so much to Sean and Tim. We'll stay on for a couple minutes if folks have questions.
And I did recognize some names in the participants, folks who already participate with our program, our naloxone program. So good to see you all here and appreciate you taking time out of your day. Sure.
All right, thank you, everybody. We will send the slides around as well, and the recording will be posted on our training website, which I'll also put the link to in the chat.